I was presented with this topic to address, and that is the difficulty in humanities to medical students. And I spoke in two things. One is that they're young, and so they have other interests that are always competing. And the other is they're doctors. In other words, their agenda in making it through medical education is so fixated, and we'll talk about it, is so fixated on science. And in many ways, thinking linearly. One of the tasks before us as medical educators is actually to help them realize that life is not lived linearly, and the illness experience in particular disrupts any linear notions that one might have for their life. And if you're fortunate, you get invited into the story, the narrative of an individual patient's life. And that invitation may come boldly, it may come timidly, but the opportunity is there as a clinician to find oneself in the approximation of that story. It's nice to be invited in. I tell my trainees a lot of my work has been done in palliative care, end-of-life care for children. That it's a wonderful phenomena if parents invite you into the story, that is crafting the story that they will live with even after the child has passed. But it's an act of hubris if you are to presume that you are going to write the story for them. That's not your place. And so one can see, even in those small reflections, that humanities is present in the practice of medicine, whether one attends to it or not. But our idea today is to take opportunity to discuss that a little bit. And might I have an advance of the slides? I don't.
Yep.
Advance. Now, I stand before you today as the Marjorie and William Sirridge Endowed Professor. So this is an endowed professorship that I hold in great recognition of the pioneering, in one sense, ideas that principally Marjorie held and created at the medical school some 20 years or more ago. When the humanities were not routinely addressed in medical schools across the country. I grew up in medical school from 79 to 83 in pediatric training, and then neonatology training from 83 until 1990. And then I practiced for 30 years as an intensive care neonatologist. I now practice only follow-up care, looking at neurodevelopmental outcomes of children who once spent time in the ICU. And I find great pleasure in that. And I came to this opportunity to work with the medical school a number of years back when I was approached for consideration of a chair. And yes, I'd be happy to do that. Why do I deserve this honor? Because the dean said we need somebody, and I made myself available, I guess. But I found that the work that I'd done in ethics education and palliative care education, as well as clinical practice, lent itself towards the intersection of the humanities and medicine. So I've endeavored to live up to the wonderful vision that the Sirridge family has had and retains. So I wrote this little timeline about when the office was established in the 90s. And again, just having been trained through the 80s, it was not normative, even for bioethics to be taught in medical schools before the 90s. It really became much more prevalent from 2000 forward. So that's one piece of the humanities, but there's so much more, as you know. The humanities are rich with diverse areas of study, of inquisitiveness, of reflection. And I think that the vision that was set forth by the Sirridge family has really matured really not in much my responsibility. I was blessed with the already extant development of the department. I have worked, if I've accomplished anything, it's because I've stood on the shoulders of giants like Dr. Monroe. So the next slide. And we'll go past the timeline. Yeah, so this mission is pretty self-explanatory. There's a need to integrate the arts and humanities and ethics into the study and learning practice of medical students at UMKC, indeed across all medical schools. And this is still ongoing. It's still developing. It's not reached a level of excellence that's universally retained across American schools, both allopathic and osteopathic, nor is it that way across other schools, principally allopathic around the world. Humanities are oftentimes scant or hardly seen. Exposure basically has been woven into the 6-year curriculum. And you're familiar with the BA&D 6-year curriculum. We're one of very few schools in the country that still provide that path, but I think it's provided well. And again, hats off to the Sirridge family and to one of my predecessors, Dr. Monroe. Next slide. Now, I like this piece of art because it does a couple of things. What do you see? And what else do you see? It could be a deformed heart. Oh, okay. But even if you say these are hands, what are these hands doing?
The lack of a better word in my brain right now, care.
Perhaps they're at least offering themselves, they're extended to help. And even as recently as this morning, I was teaching brand new medical students that our whole reason for being is the patient and the care of the patient. So here we have a wonderful sketch, which is actually produced by an assistant dean, Katie, the bar, okay, getting and shame me, who's a vice dean up at St. Joe in our campus up there. So yes, Spears, thank you, Katie Spears. And we offer the opportunity for artists, photographers, poets, literarily inclined persons to show us their stuff once a year with a publication called The Human Factor. That's a publication that comes from the Department of Medical Humanities and Bioethics annually, and we have fun composing it. We solicit input from faculty, staff, and students. And there's no reason why those from this campus could not submit. And then beyond that, we actually have, and we'll see shortly, an opportunity to experience the humanities in present at the Diastole Center, art exhibit and exchange. So the goal that I see is that physicians have to learn to interweave their developing scientific knowledge, and it is developing, with emotional intelligence. I would well imagine that you aspire for your own physicians to share some emotional intelligence. And critical thinking skills, which, yes, those happen along the path of objective, rational thought in the sciences, but it also, critical thinking skills are not just embellished, they're made better, they're expanded by knowledge of the humanities. And that also then aids in our understanding of social context. And what more tumultuous time, say 50, to live in America where our social context has been so disrupted. And yeah, I grew up in the 60s, and I might have been very young in 68, 69, but I remember the tumultuous end of the 60s. I lived in Hawaii. My dad was a Navy man, 42 years. And I remember living in Hawaii and as a 10 or 12-year-old kid seeing all the ships that were leaving to go to Vietnam. And yeah, my dad went once or twice, was on a repair ship, a ship that helps repair other ships that need help. And it wasn't just Vietnam that rocked the 60s. There were race riots, there was political unrest. And here we are 50 years later, and I'm turning to my kids, and I recently was made a grandfather, and realizing that, boy, where have we come in 50 years? It's like, did we move the needle at all? So I'm very conscious of that now as a physician and educator. And we draw in the social determinants of health as part of our inventory of what's contributing to the health of patients and families. So you can well see that the humanities are very much intertwined there. Our next slide, please. The question of, okay, so what comprises the humanities might be something that I have to field from other educators and also from other physicians. So, you know, there's a number of ways to look at the arts. Certainly as a pediatrician, I recognize the value of art therapy and our child life specialists and art therapists. Any expressive therapist may be very helpful in dealing with chronic and complex illness. Arts for health and community arts, arts for environmental improvement, that is art used to ease an atmosphere in hospitals. I would tell you, I've been in about half of the children's hospitals in America, and art absolutely dictates, or at least determines in some sense, the aura of the hospital, as does light. And I would invite you all to visit Children's Mercy Hospital, my home base, and visit specifically the chapel. Not because I'm asking you to go on a religious or spiritual adventure, but you can do that if you're so inclined. The chapel was built about 12 years ago. It is the most open, light-engaging space I've ever experienced in a hospital, let alone a pediatric hospital. It has a wall facing the east with prayer rugs available for Muslim patients, families, and staff. It has religious texts from all of the major faith groups, not simply the Abrahamic faiths. There's a prayer wall where you can insert your private prayer into the wall, and the chaplains retrieve them and offer prayers privately, but on your behalf, if you've requested them. I've sat with children who were dying in that space. I've seen children baptized in that space. I've heard Native American drum circle practice in that space. And there's a library of religious texts, spiritual substance there at the chapel. Just an invitation to see where art in a hospital, even if it's the art of how we use the light architecturally, and how that is viewed and utilized in an open space for the spiritual well-being. I dare say that part of the humanities does include touching that spiritual dimension of each of us. Humanities and arts as a source of influence on daily practice. Now, here is a nice consideration, and I'll have to say I've seen this before, never put it in these words. A literally interested nurse who draws upon a literary experience to shape the manner in which she practices and interacts with families. Anybody had a nurse that's so inclined? I think I've seen it maybe unwittingly, but listening, watching, and thinking, just like I recognize when some nurses are standing in first position. Oh, you study dance. It's a door to a conversation. And it's always helpful. Humanities and Arts and Medical Education sort of wrote intellectual academic inquiry into medicine from the perspective of the humanities, that's doing interdisciplinary work or doing field work, if you will. Anthropology is a field that I relish. Medical anthropologists are few and far between across this country, but I've never listened to one speak or read what they have written without being moved. Insights from the field. Next slide. So the human body is this opportunity where all of these things are intermingled and entwined. There's natural and existential dimensions to the human body, and it's crucial that medicine be able to encounter both. So we have to take this intertwining seriously. If we're able to accomplish the task, then we truly can integrate interdisciplinary practice. We can look at the philosophy of care. We can look at the narrative model of the patient's experience and the entering in that the clinician has. Bioethics isn't just rote autonomy, beneficence, non-maleficence, and justice. That's the old Georgetown mantra of 4 principles, Beecham and Childress, but bioethics is far more than dealing with principles. It engages people like you and I who aspire to be virtuous people. What would the good doctor do? How would the good patient respond to and fro of care? So core medical humanities bring these concerns to the heart of medical education. And this is why we have them. Next slide. So what do we do at UMKC? I thought I'd describe what we do first and then how we arrive at interfacing with difficulties or problems. What the Sirridge Center, now department, set up was an opportunity to engage humanities education in every year of the 6-year program. I would tell you that's exceptional. 20 or more years ago, when I was at the Medical College of Georgia, right after I got out of the Army, I worked with a core group of people to have a longitudinal ethics curriculum over 4 years. That was very hard to do. But to integrate humanities, to touch every student over a 6-year continuum, I think it was quite an undertaking, and it's been accomplished, I think, very well. So in the year 1, this is one of their baccalaureate studies principally. The only medical exposure that they have is the fundamentals of medical practice, which is a lot of didactics, but then it's balanced with what's called a docent experience, which I was doing this morning, where a group of 10 or fewer students meet with an individual clinician, and she or they will present a topic, or they will help the student learn interviewing techniques, professionalism. Basically, I tell them it's how to look, think, act, and speak like a doctor. But it's not terribly simple. Also, in the first year, they will have clinical research teams experience. So this was inserted just last year. It used to be the clinical teams or clinical teams experience, but we added research. So half a day of clinician exposure, half a day of research exposure across 1 week at the close of the first year. And they also are taught medical terminology, which is asynchronous online. Year 2, the fundamentals of medical practice continue during the 3rd and 4th semester. So we had Jerry Woods, who's a retired pediatric oncologist, teaching year 1. We have Amy Patel, who is a breast radiologist who's been very popular and lauded with all sorts of things, including recognition from the chiefs. She teaches fundamentals 3 and 4. The history of medicine is taught by Leslie McNulty, who has a doctorate in bioethics and a master's in philosophy. And then year 4, we engage the students in physician, patient, and society. Again, Dr. McNulty and others will teach that. And PPS 1, which is 1 semester, goes through decision-making skills, public health assessments, using lectures, using also problem-based sets and learning and small groups, excuse the typo. PPS 2 introduces the students to medical ethics and palliative care using lecture and small groups and assigned readings. And that's it. So now we're moving into years 5 and 6, which if we were to consider on par with the traditional 4+4 medical school would be years 3 and 4. But before doing that, just wanted to give you an idea of the faculty and the things that they teach. One of the attributes of the first year, which again is unique, at least to UMKC and how it's played out, originally started as a demonstration project, a small grant. It's called the Mentor Program, in which first-year medical students in April, so the end of their first year, are partnered 2 students per 1 mentor this year, because we have over 40 mentors that are volunteering their time. These are senior citizens in John Knox community. And some of them were chemists, engineers, educators, doctors or nurses. And these folk are volunteering their time. They meet once a week with this student group of 1 or 2 students. And they basically help the student learn what's important. What do people want out of the position? How do you speak with senior citizens? How do you regard them, not simply as aged, but experienced, with lives that have been rich with opportunity and creativity? And then at the end of that 6 weeks, they write a paper about what they've learned. And it's always bi-directional, right? The senior learns, the students learn. The student writes a paper, the senior grades it. And is turned in, and it's simply a pass-fail experience. But it's, again, rich with opportunity. Other medical schools have done similar, but not exactly the same thing. I know one where you partner with a patient who has a life-threatening condition. It might be HIV/AIDS, it might be cancer, it might be any number of things. And you see that patient through the continuum of your medical education until you graduate or they pass. And you learn by that continuity of care and that experience and their lived experience together. So I think this mentoring program, which again started as a small grant, has continued. It just caught fire and is a wonderful experience for our first-year students. Next slide. There's Amy, you may recognize from other media. The service learning project is actually present in both year 1 and in year 2. And these are opportunities for students to get out of the medical school into the community and give of their time, their effort. Some of these have been working with food banks, some have been working at community gardening, some have been at Ronald McDonald House. There's a list that Dr. Stephanie Ellison retains. She's in charge of this aspect of education of probably 30 different opportunities that have been utilized by students in the community, both here and at St. Joe. Next slide. Trent Myers is a graduate of the UMKC 6-year program, and he is now in charge of behavioral sciences. He was mentored by this wise guy on the front row, Dr. Monroe. And I think that he and I both are proud of Trent's progress and his stepping up to teach. It's nice to have a young, enthusiastic faculty member, because I often look around and I see people that look like us. You know, we're a little bit aged. I had to face that question today with my student group, and we were talking about Medicaid, and they said 65, and someone said, "Oh yeah, that's for all the old folks." I said, "Wait a minute, I turned 65 last year." Yeah, so categorically, for statistical purposes, the government says I'm aged. And yet, we have to be able to say, we've got young faculty members that are engaged, you know, they're involved. It's not all a bunch of graybeards. Excuse me, ladies. I will not say blue hair. Leslie McNulty, a new faculty member this past year, and I'm really proud of her stepping up. She's stepping up and stepping in. She's part-time and will grow in her FTE, I'm sure. She anticipates developing an elective in women's issues in medicine. 70% of our medical school class is women. When I went to medical school, it was about 30%. Stuart went to medical school, it might have been 5%. So things have changed, and for a pediatrician and my obstetrical colleague, all for the better. But I know some excellent women surgeons, including neurosurgeons, one who operated on me at the Brigham in Boston about almost 5 years ago now. So next slide. Commonly taught selective, so we get through the first 3 to 4 years, and then we enter into the opportunity for the students to select amongst these courses something that they will take during their year. So each year. And we have medicine and art taught by Bill Ritter, who's a cardiologist nearing retirement, who also has a master's in art history. Medicine and film is going to be taught this year by Alan Davis, one of our admissions officers who has a PhD in theater. Medicine and literature I've taught before and have been asked to teach again. It will probably be pandemic themed with a broad array of literature, but obviously Camus' The Plague, for which a major paper will have to be written. Medicine and music taught by Trent Myers. Medicine body image, so how one regards the body and how the art of medicine is practiced on and with and inside sometimes a body, and what body image means. Medicine, law, and bioethics is something that I've taught in the last 2 years. I've tweaked it to really be addressing social justice issues because of historically what's transpired. Philosophy and medicine will be taught by Dr. McNulty this fall. And we sometimes are called to give guest lectures at different places, including the Emeritus. In development are some other electives that you can see there. I had the pleasure of working with the UMKC law professor, Yvette Lindgren, in developing what we had hoped would be a well-attended elective, looking at medicine, bioethics, and reproductive justice. Well, we were offering it in June of last year. You have to have 10 students or you can't hold the class. We only had 4 students. If we had offered it in July of last year, I imagine we might have had 40 students, just given what's transpired with the Roe v. Wade and the Dobbs decision. So we are seeing a lot, or anticipating a lot of interest as we offer that, not this calendar year, but the following one. We're going to actually be teaching law students and medical students together in a seminar course, and this is an experiment. I hope it works. Women's issues in medicine, I alluded to already. I'm eager to have a partner join me in medicine, poetry, and writing. I have written a lot, and I think physicians should be able to write. It's intriguing in our 6-year program. Some of our 18, 20-year-olds who come from high school and they start medical school and they're asked to write something. And I'm seeing some of them in their year 5 and 6 with Selective asking them to write a paper. And it's very obvious who did well in English comp or who has a handle on literature and feels comfortable with it. Because some don't even know how to apparently use grammar and spell check. So there's room for improvement. Spanish culture and language in medicine, that is the intersection of those. I'm hoping that we can put together as a selective. That is one of the things offered in the last couple of years, in addition to Spanish for physicians, which is more language-based and general elective to be taught in the early years, which could equip our physicians with a skill set that makes them better at caring for Spanish-speaking persons. And then because of my military track record and the fact that once upon a time there was a medicine and war selective, I will be reviving that selective. And I'd be happy to take on a more recent veteran. That's a veteran of the 91 war. Next. Humanities and bioethics, there's a growing demand. There's some diversity in who we have teaching. We've partnered with the Kemper Museum, and they host year 1 student docent groups, and they use visual teaching strategies, some of which I walked you through with the hands. What do you see? What else do you see? Why do you think it's the artist is conveying things thusly? We do have a collaboration with the folks over at KU and their Department of History and Philosophy of Medicine. We have a chapter of the Osler Society, which is named after Sir William Osler, father of modern medicine, if you go back 110, 12 years. But he took teaching of medicine to the bedside instead of in the amphitheater. And then I am trying to network with health humanities consortiums and members across different universities, as well as within programs in bioethics. So I'm a member of the Association of Bioethics Program Directors, and twice a month I'm on a Zoom call with 20 some odd similar folks doing wonderful things nationally. And sometimes we contribute to position papers. Next. So there are really a number of places where if we think about the humanities, as was the case in this paper in medical education, and again, excuse the typo on reflections. And if you go back to those selectives that we offer, I think you see that they sort of fit into these 3 broad categories: the embodied human, the patient as object and subject, and the ways in which we see things. And I tend to like some of the verbiage that was used by Dr. Rita Sharon, an MD and a PhD, the PhD in narrative literature at Columbia, in which she says that the humanities help us see things differently. And since physicians spend a lot of time looking at things, and I told the students this morning, a lot of what you do is pattern recognition. See this, you think this, you organize your thoughts thusly, and then you develop a differential diagnosis, a list of possibilities, and sort of check things off by laboratory or exam findings or imaging studies. We want you to see something differently. I said, you're going to learn to look at people differently. Not in a judgmental sense, but in a recognized pattern-focused what this means, Sam. Because if I can look and organize and then ask myself what this means, I can be responsive to whom? The patient, which is our reason for being. So that's the task that I see, and I do believe that the humanities help us accomplish that. Next. Human stories are important. You heard my mentioning narrative already. And then the place of science. It's not like humanities first and science second. It's working together, intertwining, as I said before. So how do we value science? How does that change the way we use what we observe in a humanities sense? Where does science belong in the list of priorities in education and in practice? Medicine itself, I would tell you, is not a science. It's certainly not a pure science. It's not a basic science. It's a conglomerate of many sciences that come together in the context of human biology. But that human biology is also rich with a psychosocial, spiritual dimension that helps define the person in a context perhaps of culture, certainly in a historical context, perhaps imbued by race, ethnicity, economics, education, ethics, and religion. And so situating things and seeing how they work together, but also where we recognize the attributes of some of these as different sciences and move beyond what I experienced. Unfortunately, I think in my education was a lot of reductionism. You reduce everything to its fundamental parts. You understand that, then you understand the whole, but not really. It takes lived experience beyond that type of reductionist approach to truly be a good physician. Next one. So I also have this to turn to, which was published just 2 years ago. The American Association of Medical Colleges, or the Association of American Medical Colleges, which is our big academic association for medicine writ large, and in particular medicine in an academic sense, as opposed to, say, pediatrics or general surgery or what have you, put forward this publication, and it was designed for medical educators, faculty, students, physicians, and leaders in academic medicine, and it gives some guidance about intertwining the humanities, as I mentioned. Next. We've had invited speakers, some by Zoom and some in person. I was at Vanderbilt with Dr. Churchwell when he was a pediatric ICU doc, and I was a neonatal ICU doc. And then he took a step towards academics and administrative medicine and moved up through the ranks and is the president and CEO of Boston Children's Hospital, which is like #1 children's hospital in my mind. Children's Hospital Philadelphia, both excellent institutions, but Kevin is a superb educator. His twin brother is a cardiologist, adult cardiologist in Nashville. So this is one endowed lectureship. That's the Novak Burton lectureship. We also have the Sirridge lectureship, and I reach out to find humanities persons who have worked with medicine. This year, we're bringing in Dr. David Dukas, who's a family medicine doc and director of the Humanities, I think it's the Wright, WRIGHT, Family Center for Humanities and Bioethics at Tulane. And he'll be here the 1st of March, if I'm not mistaken. Next slide. We do scholarly works, publications, give talks. Next slide. This was something I had to put together for, somebody's counting things over the last 5 years. Next slide. Here's some more art. This by a medical student. Very expressive. amidst the pandemic. Next slide. Further examples of the human factor, and we're going to put a compendium together in the next couple of years. Next slide. And again, an invitation which will make certain that you have an invitation to, through this august body, to contribute. Usually the invitations go out in August to September, and the compilation is put together by November, and it's published in January or February. So we'll see one coming out shortly. And this is all student, faculty, and staff artwork. The saxophone, I think, was Trent's work years ago, Dr. Myers, child and adolescent psychiatrist. Next slide. So this was the invitation. We'll make sure again that we get it out for you to beyond the human factor, which is the in-person reality. And I think we have a photograph on the next slide that just gives an idea of some of us at the Diastole Center, which is a center across the street from, sort of catty-cornered from the dental school, across the street from the Allied Health Sciences building, and was purchased by Dr. Gray Diamond, isn't that correct? Mm-hmm. And you will see fantastic artwork from around the world. Next. A far-reaching faculty say, oh, how big is the Faculty of Humanities? Well, if I count all the docents, that is everybody that helps mentor students, it's pretty big. We have people from virtually every specialty: pediatrics, internal medicine, surgery, radiology, family medicine, emergency medicine. Next slide. And sometimes our mentors are docents. Here we have a docent group having a picnic, and in the middle you see a docent group at the Kemper, and then a couple of guys throwing a ball around. We try to make it a little bit more lighthearted and not so hard and fast, compelling, like so much of medicine education is. We have changed the support staff, and you may have interaction with Susan Mason. She's wonderful, came to us from Gilda's Club. Are you familiar with Gilda's Club? Surprised how many people don't know about it. Gilda Radner, she and her family established this to be a supportive resource for persons and families touched by cancer. It doesn't matter what. So Susan worked there for 8 years, I believe. Next slide. So I thought I'd go to the literature. We'll do a couple minutes and then stop for Q&A. Thought I would go to the literature to see, well, what does the literature tell us about challenges in teaching? Well, the reality that students prioritize biomedical knowledge building. Sometimes, unfortunately, the institution themselves downplays the humanities. Not the case at UMKC. The healthcare system undermines the medical humanities. What do I mean by that, or do they mean by that? You've heard of the hidden curriculum, perhaps? So at one point, we have a curriculum that's taught, right? But then there's the curriculum that's not taught except by observing how doctors act. Understood. We will follow up. And so you can learn one thing, and then you're experiencing another, and that's the hidden curriculum. And what we see there is that humanities and ethics and professionalism sometimes is downplayed. And the labor division and identity formation, just putting together a curriculum is hard. Next. This was a Danish study. I love this student quote at the bottom. I had thought that the job as a physician included more care, from a 5th-year student in a 6-year program. That's a discipline to get that far along. These were, again, statements by students. And I think, yeah, we have to be empathic, but there's so many other things to do. And as you all are likely aware, empathy is necessary, but not sufficient. It's great to feel as the other feels, but you have to act on that feeling. And the product of empathy should be compassion. They're different, but I think they work together. And so, somebody knowing about empathy, but not seeing it put in practice or compassionate care following means that we've missed a step and opportunity exists to do better. Next. Other things are on people's mind, even while you're having a conversation or trying to teach or at the bedside. I'd be thinking about lunch. I'd be thinking about so many things. So what people talk about and write about isn't the humanities. Go into the medical journal. We're trying to change that. And it comes slow, but progress is being made. Next slide. The process of character development is very important, and this I house under the humanities, and I use the professional identity formation because it is a continuum, and your identity grows and matures and develops over time. And students should not expect that their first or second year that they've accomplished it. But if they're not told that, if they're not taught reflective skills, self-awareness, and take the time out and get the feedback from others to develop oneself, you're not going to become that caring physician. Next slide. I think this is the final slide. This is an interesting paper from Philosophy, Ethics, and Humanities in Medicine. And it really describes how there are a couple of paths that people tend to think on. This is old school, linear, objective, rational thought, logical, scientific, modernist medicine. Withdrawing from others, practicing scapegoating then leads us to be unprofessional in our responses. This is what we want to move away from, and this is what we want to move towards. So, Eastern thought as a philosophic foundation versus Western thought and dualism. Boy, that's grounds for humanities intersecting. Postmodern acceptance of uncertainty, living in the tension of not knowing, is something that physicians have to learn to do and be able to convey and help patients learn to be able to tolerate. Giving up the fact that you're going to be in control of everything. You don't know everything and you're not in control of everything. Shared vulnerability. Being able to say, yeah, I'm human. I understand where you are this much. I had a dad once tell me, I just wish someone would say, this really sucks. And then we can move forward from that. Yeah, we need to be able to say that, or at least sit there and affirm. Then we move towards empathy, mutual recognition. We deal with the ethics of imperfection, the reality that we're imperfect persons. But we attend to narrative and the biopsychosocial patient-centered medicine. We have outcomes that are intended. We're moving with intention as opposed to, oops, things happen. We're drawing closer to others, which really is an example of altruism. And then what we result is expected professional responses. So one path leads us in a better manner towards professionalism, care, and understanding, mutual trust. The other, which we're still having to reckon with, if we see this, if we think about this, we can change. So that's why I brought this up. This is a challenge. This is where I'd say, okay, that's all I have to share. Let's do a little Q&A.
Yes, ma'am. I hope they can hear you. That's absolutely fantastic. Thank you so much. And you have really modeled all what we have been talking about, especially now in this last slide. It's also very satisfying to me to see how the principle in the medical school has become more and more important. Way back in time, contemporary. This was in its infancy, not quite infancy, but still very much under development, evolution, and this really sad. Just one little thing, you talked about art. We used to have a faculty member, not Susan, I don't remember her name, in theater, was part of the faculty, and I was director of year 1 and 2, and could do that just about what I wanted to do. So I invited her, and my students, they looked at me. Nothing was happening. And then she took over, didn't say a word. And then she asked the students to, what can you read from my facial expressions and body language? And then we started talking about that. And it was just fascinating how they became more and more open and listened to her and understood what it was all. And you also wrote reflections on, I have video and so on, things like that at the same time. But it's very satisfying to see how this is.
Thank you. I appreciate again the shoulders I'm able to stand on. I've done none of this by myself, and it's good because I've seen the field of bioethics mature throughout my career, and in many ways the field of palliative care mature throughout my career. So to have any hand in seeing the furtherance of the humanities in medical education, I feel very fortunate to be engaged in. I do aspire to partner once again. I know there was a time where there was more partnering between the Volker campus and the medical school. Yeah, I do recognize the expertise that's here and do aspire to partner so that we can co-teach. Okay, there may be a medical doctor or a PhD from over there. There may be a PhD or a master's prepared expert working together to teach the medical students. So someone who's teaching the humanities all of the time in many of its different forms, and a physician or other clinician who has insight into that interface in the clinical context, teaching the students together. That's what I aspire to do with medicine and theater. I actually have this notion in my mind, medicine as performance. When you go to see the physician, I'm going to present myself this way, I'm going to wear this, I'm going to be able to say this, and then you sit there and in the reality, you have to respond to how he or she is, and they likewise have gotten ready to see you in the clinic, and they are performing. And then you perform together, and it's beautiful if you can dance, but it's not if you're falling down. And one of the challenges I should mention that we've come across in trying to do this is the block learning that the medical school has about a 4-week block rotation versus the semester learning, and how you can work through and around them so that you can actually do the joint process. But that's my task. I will seek help where I can, but I'd like to make that a reality. Yes.
My question is, do you have any kind of feedback from now doctors that went to your program, what they think about programs, say 5 or 10 years after they are after their certification, or I say
after residency,
completed residencies, let's say.
Yes, I think this is the big challenge, as we all know, in any education, is what's the lived experience of the learner after school is done and they're in the school of life now. That, you know, the challenge, the test, the examination for physicians is 40 years of practice. But it doesn't mean we shouldn't take the opportunity to maybe 5 years after residency, reach out for some reflective evaluation. Oh, this was meaningful. Oh, you don't need to spend so much time on that. So I appreciate the thought that, yes, we should be doing that. No, I can't put my fingers on hard data, but I appreciate that direction.
Do you find that the distance between the two campuses, the med school campus and the Volcker campus, is inhibits your students from coming here and like attending conservatory performances, or is that they're so busy with their work that how can they let it go for an evening and attend a dance concert or a music concert? Or
We're encouraging them to do that as an element of self-care, which is very important. Nobody taught us self-care in medical school or residency, and some of us have colleagues that aren't here anymore because self-care was missed. I do find that the bus works well. The students utilize it. I know that some students in the 6-year program live on campus or very nearby. So the proximity issue can be one that interferes, but I haven't gotten a sense from the students that that's insurmountable. But I don't have the data there either. Can't say that I've measured it.
do they know that their ID gets them on performances at White Recital Hall or anywhere for free?
They do.
You all know that too.
They do know that, and we have a in the know newsletter for the medical school that comes out every month, and they're brought up on new opportunities, not just the scholarship here to apply for, but an opportunity for outlets, recreational. Yes.
Yeah, it is good to see that you are including the humanities in the medical education. I guess my question isn't so much about the med school here at UMKC, but the medical profession. At the time I was going through college, I had some very good friends who became very good doctors and eminent doctors who majored in history or English or some humanities course, or even if they didn't major in it, they took multiple courses during their bachelor's degree. And my impression is that over the years that those people became fewer and fewer. And one would think that to pursue the goals you're talking about, it would be nice to see more people coming into medicine, having had more of a background in English and history and philosophy and things like that. And perhaps medical schools, when they're evaluating applications, could urge this by saying you should have a course or multiple courses in these areas. And my impression is that currently most of the requirements to get into med school are organic chemistry, biochemistry, microbiology, things like that. So do you see any way to really I mean, you by yourself can't alter the entire profession, but do you see any push from your colleagues at other institutions to try to do this kind of thing?
Yes, I think that it is a recognized need. In fact, it's been studied that those that have undergraduate degrees in the humanities actually outperform those that have science degrees when we look at the medical school admissions test, and also the National Board of Medical Examiners 3 different stages before one achieves certification. So there are some measures that indicate that the humanities are an absolute requirement. The trend has been very much as you've described. Once upon a time, there was a broad-based undergraduate exposure, quote, the liberal arts and the humanities. And so, yes, the sciences were there, but now because the sciences become so technical, it used to be that organic chemistry was the linchpin. And it probably is still to a large extent. If people don't do well in organic chemistry or molecular biology or biochemistry, they tend to remove themselves from the pathway towards medicine. I think absolute removal from that path is unnecessary. I think an alteration and maybe an added semester with some robust work would still get you in. So medical school admissions committees are paying attention to humanities, but I would not be representing the truth if I were to tell you that the sciences aren't at the top. In other words, they do want people that perform well in the sciences, but if we look at the full student, what did he, she, or they do? Were they in clubs? Were they in athletics? Did they take leadership opportunities? Did they, one of the most impressive students I interviewed for medical school at Vanderbilt when I was there, I spent 13 years on the faculty there, was a young woman who majored in double major, DANT and neuroscience. You are going to be a wonderful physician. You're looking at the body and its fluidity and its use of that noggin and nervous system. And I thought, yeah, hands down, except her, no questions asked. Didn't need to finish the interview. So occasionally we come across real gems like that, but we do pay attention. And I think more broadly, other schools too are paying attention because the pendulum swung too far. If one comes to medical school already with a PhD, wonderful, or an advanced degree like a master's in physiology or something. One of the students today in my group, new students, MD only track, the traditional 4+4. Undergraduate degree in physiology, somebody else with a master's in public health, and then rich job experience. So scribe, one was a lab tech, one was a volunteer, in fact, when I left Vanderbilt in 2012 to come here, I realized that I would never have gotten into medical school at Vanderbilt. Of course, I did. I applied and didn't get into medical school there, but these students, they're going to spend a semester in China. They're going overseas. They're doing businesses. They're running. It's just they come with a repertoire that's just remarkable, but predominantly still in the sciences. So we have room to grow.
Do you find our 6-year program inhibits taking more humanities related courses, or
I think that
you
if we,
figured out a way to truly integrate it at the same level?
I think if we look at the last question and your question together, the answer has to be yes, because one with a bachelor's degree or a 4-year experience at college or university, as you know, it's so rich in so many ways. And the humanities are present, but likely in the mind of the student, still relegated less priority than the sciences. So even during the 2 baccalaureate years in the 6-year program, yes, they have humanities exposure. No, I don't think it's on par with what they would have if they had had an undergraduate degree. So yes, I do think it's a little bit stifling. But people come to medicine at age 18 thinking this way, blinders on this way, and not this way. Yes.
on the other side of the doctor-patient interaction, how can the general public be encouraged to not be a passive recipient? And my example is that the summer after cataract surgery, my migraines came back. So I went into the checkup, and immediately before I could say anything, he started writing the prescription. I said, but it's not a problem. I do what I've always done. I drink strong coffee and they go away. We then had a really interesting conversation, and he explained how the caffeine affected, and I was so pleased to know why it might work. But it does help if a patient asks questions, and sometimes it's so intimidating that you passively take the prescription and walk out and don't answer that.
That remains a challenge in every clinical encounter, and especially when one is engendering a relationship with a new physician, specialist or otherwise. And you need to develop, did I say the chutzpah, to speak up for yourself. I do know, and I've seen this when I was making a decision where I would have my neurosurgery. I went to the Mayo in Rochester, and it wasn't that I was treated like a number and herded like a sheep, but I was given a spiel. This is what we're going to do. There wasn't any give and take. This is what we're going to do. And then I went to the Brigham in Boston, and I had a neurosurgeon spend 2 hours with my wife and I. He went through every pixel of every CT scan and MRI, and he said, this is what's going on. It's one of these kinds of different cell types. I'm going to go down the hall and ask my neuroradiologist if he agrees. And if he does, I will come back and make a recommendation for which type of surgery to do. Okay. He was back in less than 20 minutes. And he said, if you choose to come here, this is what I recommend we do. And he spelled it all out. And he said, now ask me any question. And he turned to my wife. Same thing. And one of the things that I appreciate, and this is trust, is what led me to Boston. I said, you know, I'm a doctor. My coping mechanism is intellectualization. The more I learn about something, the more I'll understand it, the more I'll be able to deal with it. Okay, academics are like that. So I've read a lot about this condition. And I've read that it can take, 4 hours or more for this surgery. He looked me straight in the eye and he said, Doctor, if it takes 4 or 14 hours, I will be there for you. Oh, sold, right? I mean, what more could you ask of someone that's going to operate on your brain? And I was under anesthesia for 12 and a half hours. And it was a remarkable experience, life-changing, certainly. And it was a matter of him giving space to have that dialogue. The other doctor didn't really give that space, and I was able to speak up, but it still didn't become discursive. It was still broken. I think all of us as patients need to be able to speak for ourselves. And sometimes that means we have to, my wife's a funny woman. And sometimes if she gets upset, she goes, I do that. Usually people do that, right? Just stomp their foot. I said, what are you, 8 years old? She said, no, I'm just making a point. And I think sometimes that's what we need to do, is we just need to stomp our foot, clap our hands, or just, no, that's not good enough. Sit down and tell me why.
Yep.
It's hard. But through my own experiences as a patient, as well as years in practice, I think we all need to advocate for ourselves. And we're trying to teach physicians to be more sensitive and to realize it's a mutual, it's a shared decisional process. It's not a prescribed, as you started with. He was getting ready to write the prescription. So there needs to be a sensitivity. Hopefully teaching humanities will enrich that. But for all of us in the room as patients, yeah, we need to speak up for it. Sometimes a loved one with us will do that. Sometimes even an adult child with us will do that. My wife will speak up for me. She won't speak up for her. I have to speak up for her. I understand what you're saying. There's room for improvement.
This is not an unfortunate experience. I mean, it ended up being mutual.
Yes, yes.
He then explained how the caffeine worked.
Yeah.
And why I didn't need the prescription.
So you were willing to tell a story. He was willing to listen. Then he was able to explain, and you walked away with the satisfaction.
And learned a lot that I could not have otherwise known.
But he was willing to respond to your observation. That's a matter of, if I could say, teaching physicians to retain their sense of curiosity. There's a sense of curiosity that lends one to even go to medical school, become a doctor. But if life is so mundane that all you're doing is writing prescriptions or telling people to go get this study or this test, or then something's amiss. So he retained curiosity, and when you mentioned the coffee, was able to take off there. That's actually very satisfactory. Yeah. Oh, should we wrap up? You, sir, in the back, you haven't asked the question yet.
I think society has had a big push on STEM as TPM and as a political push as well. And the arts are trying to sneak in there. So don't call it STEM, call it STEAM. STEA with the I've had similar experiences at Yale in the past few years that we're talking about. And even with someone who can very well stand up for themselves, the barrage, kind of a unbeatable wall of we're the expert.
Yeah.
I'm from Minnesota. We all love mail. Since then, this just the last one of the best. One of the best physicals I ever had was when I was teaching at University of Iowa Hospital of Defense. There was a doctor there. He was retired, but he came back to hospitals and did some work. He was my doctor. And I took all the tests. First thing he did was, come on to my office. We sat down. He listened and talked, and I talked with him for almost a solid hour. And I will never forget that. Because he was the kind of person that, as you say, has a curiosity and has the time to be able to do that.
He made you feel valued.
Absolutely. Yeah.
And doing that, you would trust him if he said, I think we need to do this next step. Right. That's what we're hoping to create in our young physicians. Thank you all for your attention today and the opportunity to be here.